Rick, before we would do this, I wouldn't believe a word we're saying. So where are we getting our information from?
Well, Fran, we actually have a good source for this, an excellent source for this. Over most of the winter, since Fran and I are both healthcare professionals, we realized we were going to have a role here that we would really look forward to. And we spent a lot of time, and we can talk afterwards with anybody who wants to, resourcing and continue to resource medical publications. This multi-volume publication, The Medical and Surgical History of the War of the Rebellion, is basically the medical official records of the Civil War. It is full of illustrations, as you see on the left. It was published about 10 years before the OR was. This is a tremendous resource for anybody interested in the Civil War, but you got to put on shoulder pads because it is really thick and detailed. Fran, you're going to have to drive the...
Yep. So, and it's got pictures.
Lots of them.
So this is from that journal, correct?
Yep.
Yep.
Yep. Line drawings, there aren't photographs in them, but these are line drawings made by artists that are scattered all through this. And the reason this came about was to educate physicians and surgeons about the care of the wounded and the sick. And we're going to talk about the wounded, but we're not going to talk much about the sick. That's a whole nother lecture. You hear that, Wayne?
Yeah. So we need to come back to do sick. So before we go, we've got to talk about some things and get everybody up to speed. So Rick and I are big game show fans. His daughter was on Jeopardy. You're going to see us play a game of Jeopardy here. So here's the question. What do these cities have to do with our lecture today? And we'll tell you. Denver, Colorado, population 620,000. That's the number of soldiers it's estimated that died in the American Civil War. Soldiers and sailors. Every man, woman, and child in Denver, Colorado. Tallahassee, Florida, 183,000. Killed in battle. 620,000 died, 185,000 estimated to killed in battle. Atlanta, Georgia, population 432,000. That's the one that died of disease and infection. Las Vegas, Nevada, this is probably the worst statistic up here. This is the number that survived. Post-traumatic stress, disfigured, amputations. So you got to think about that when the bullets stop, it doesn't stop. Johnstown, Pennsylvania. That's where we're from. One-free city. One-free city. So, Wayne, your computer's about to restart on us. It's about to restart on us.
Oh, no, we'll turn it. Not to restart.
So Rick and I are going to play our game. We're going to come back and then if Wayne invites us back, we'll talk about the disease. But 70% of the deaths are not related to battle wounds. We're here today to talk about surgery and anesthesia and battle wounds. But there's 435,000 people that aren't going to even die of that. So we're going to play Jeopardy.
Real quick.
You go first.
Jeopardy.
All right, we don't have it all here. Rick, what is it? In the form of a question.
What is vitamin C deficiency, scurvy? Because it weakens your gums, your teeth fall out. It's a big problem in the Civil War because if you don't have your four front teeth, what can't you do? You can't rip open a paper cartridge and pour the gunpowder down the barrel of the gun. That's where the term 4F comes from in draft designation.
Okay, this is mine. I'm cheated. I know this. So another disease related to how the soldiers were fed is night blindness. All right? So when you go to sleep at night and it gets dark, your eye produces a chemical called rhodopsin that allows you to see in the dark. You need vitamin A to do that. They don't have it. These two medical conditions are problems. So why don't they fight at night in the American Civil War? First, there's this, and second, it's really dark. There's no street lights around. So they don't like to fight. They can do that. Okay, Rick, ready?
Yep.
Form of a question.
Yes, sir. What is smallpox? Smallpox is very common in the Civil War, mostly in rural soldiers that have not been exposed to big city diseases, but there were vaccinations available, and it was policy in many units to have your soldiers vaccinated against smallpox. But it could wipe out literally ranks of soldiers. Next, Fran.
Mumps and measles. You don't even think about that anymore. We've been giving our kids MMR since 1963. These soldiers would come in, especially from rural areas, would be exposed to mumps and measles, and they would get a sequelae of that, and they would die from that. Now, all this stuff we're talking about is going to affect people going to sleep. So far, none of these people, except maybe the night blindness, we would do surgery on. Unless it was murder. Okay, Rick, ready?
Yeah. This is hospital gangrene and some of the infectious diseases. We're going to touch on these when it comes to surgery. But these diseases, these infectious diseases, remember, no antibiotics, not even an understanding of sterility, ran rampant through the medical wards.
So you all had a boil water notice at some time. Cholera is one of those bacteria that makes soldiers sick. There's no treatment plans. Probably the teeth problem, they didn't have fluoride in the water either. All right, Rick, last one.
Yeah.
Ready?
Yep. So the largest killer in the American Civil War is acute diarrhea. And if you are, what's that?
Where did you get that picture? Seriously.
It killed more people than anything else in the American Civil War. By convention, though, I'm happy to tell you that if you were answering nature's call and so indisposed, you were not to be shot by the enemy. All right? It's a civil war.
Right.
Now, I don't know if you have your gun, if you can shoot back, but I'm thinking that's probably not what they're going to do.
Right. But all these minor diseases that we're laughing and chuckling about, when you get sick, it all ends up in the common pathway of diarrhea and dehydration.
Whether it's malnutrition or some of these other disorders.
So Rick, we got to talk about the next problem that we have in the Civil War. How many physicians do we have, and what are they doing?
Well, medical education in the Civil War, pre-Civil War, is very different than it is nowadays, folks. The military at the start of the Civil War had exactly 113 physicians, of which 24 went south. By the end of the war, they had 12,000. So in a 4-year period of time, that expanded exponentially. Before the Civil War, the U.S. Army had one 40-bed hospital in Leavenworth, Kansas. At the end of the Civil War, there were tens of thousands of hospital beds around the country. In the Civil War, there were exactly 20 thermometers in the Union Army. The Confederates had 3,200 physicians, so they expanded from 24 to 3,200. But you can see the Union Army had the better ratio of medical care to injured. Every soldier was estimated, every soldier was estimated would suffer 2 to 3 incidents, whether it was an injury or a medical problem, every single year. So it's not like you got sick once and it was over with.
So how
it
long
happened
did it
every
take you
year.
to become a physician?
A medical education now. Wayne read that bio. I was kind of impressed with my own bio. 4 years of college, 4 years of med school, that's 8. 5 years of orthopedic residency, that's 13. My wife let me do 1 more year of training and then she said, get a job. That's 14 years. But things are a lot different in this day and age. But that was even back in the 80s.
You'd never get that done in the Civil War. So the next slide, what's the education?
Basically, doctors were trained before the Civil War in an apprenticeship. They would team up with the town doctor. The town doctor was not doing surgery. Very few physicians had ever even seen an operation. They were treating the problems of their hometown. Pneumonia, tuberculosis, infections, broken bones. The rare doctor that went to medical school would sit through lectures in drafty auditoriums like this. They would go to class for 6 months. They would take no tests. They would take no notes. They'd hear 6 months worth of lectures. They'd come back the next year and do the same thing all over again. Same curriculum. And then they might go to a hospital where they would serve time in the hospital in a residency. So surgery was not being done frequently. It was certainly not being done in most places in the United States. Fran, anesthetic was invented when?
1846.
Yeah, 1846. So it existed, and we'll talk a little bit more about that. But the average doctor in America had no idea what to do with an injured soldier.
So now, we've got these 6 soldiers with diarrhea. We've got these 6 soldiers with diarrhea, measles, a million things. We put them on a battlefield, we move them into position, and we start firing things at them. So we're going to talk about really quick, what is hitting our soldiers on north and south? Well, first of all, we have small arm injuries. Bullet, 94% are due to the mini ball. Now it's estimated it takes 145 bullets to hit 1 soldier, right? So the volume of these soldiers being hit, more is being fired at them than coming out. This is going to go into the anatomy of one of these shells. Artillery, 5% of artillery shells. I've read one thing, 745 artillery shells to get 1 man. So remember, we talk about firing. The word accuracy, I don't even use accuracy on my tour, right? And then, of course, there's edge weapons, bayonet and saber. Now, the mini ball fires 400 yards, 4 football fields. The artillery can 1 to 2 miles. How far does a saber? What's the effective range of a saber?
About 3 feet unless you're lunging, then it's 5 feet.
Then it's 5 feet.
Right.
And how many of those do we have? What's that Spotsylvania thing?
Yeah, the quote from Spotsylvania that there were 14 bayonet wounds in the campaign in Spotsylvania, roughly the same number of men kicked by angry mules. So they were rare. I mean, we have a picture there. Many of you know that there was an officer bayoneted to death in the wheat field, but this was really rare. These wounds were caused by a revolution in small arms fire. I'm just going to start this at this end. I started one at the other. Many of you have probably seen and felt and held a 58 caliber Minié ball or mini ball invented by Claude Etienne Minié, a Frenchman. A very heavy piece of lead, but soft lead. When it went into the body, it ripped open big wounds. When it hit the bone, it's soft lead. It deformed, it tumbled, and it just ripped people apart. Large wounds, shattered bones. Kinetic energy, if you remember the formula, 1/2 mv squared. M, big mass, a lot of energy that goes into that. It revolutionized accuracy, but it really created a whole different subset of wounds that we were not that familiar with.
Where are they getting hit?
Well, we've talked about how the wounds occur. Let's talk about how they occur on the body. About 1/3 of injuries are in the upper extremity. Now, if you're hit in the arm, you've got a pretty good chance of living. Only 3% of people die. However, if you're hit in the leg, and that was also about 1/3 of people, a much higher mortality rate. Why? Large blood vessels, large nerves, and the closer to the trunk the injury occurred. If you were shot through the wrist, you had a very likely chance to live. If you're shot through the hip, right below the pelvis, that's almost always a fatal wound. The other thing that mattered was whether the bone was involved or not, and we'll talk in some detail about that. If you were shot in the trunk, the chest, the abdomen, pretty good chance you're going to die. If you're shot in the abdomen, virtually certainly you're going to die because you're going to develop peritonitis or an infection from the injury to the organs. Oddly enough, if you're shot in the chest, if it doesn't hit, as Fran said, your chitlins, it doesn't get your heart, it doesn't get a big vessel in your lung, you got a reasonable chance of surviving that. If you're hit in the head or neck, now that's 2 different groups. If you're hit in the brain, that's one thing. If you're hit in the head or the face, that's a whole nother injury, but still a pretty high level of mortality because even nowadays, if you have a significant brain injury, you have a high mortality rate. The chances of a wounded soldier dying in the Civil War was not as bad as we think. Only about 1 out of 4, 1 out of 5 soldiers died of the injuries they sustained. And when we talk about some of the complications of surgery that these men went through, I find it astounding that the results were that good. Just a real brief rundown of head wounds. Many of you who are familiar with the Battle of Gettysburg in some detail will recognize these 3 people. Again, if you're shot in the brain, we'll talk about a contribution that an important gentleman made of triage. If you're shot in the brain, at many levels, you're going to be pushed off to the side because it's a mortal wound. And the physicians and hospital staff know you're not going to survive it. If you're shot in the face, that's not the same as being shot in the brain. Gabriel Paul shot through both eyes in and out at the Battle of Gettysburg, rendered blind but survived his injury. Confederate General John Gordon, if you look closely at that picture, you will see the left side of his face is disfigured from an injury he suffered at the Battle of Antietam, and he often had his picture taken in half profile. Waller Tazewell Patton, I believe the great-great-uncle of George Patton? Great-uncle, one great. Shot through the jaw coming across the fence on the Emmitsburg Road at Gettysburg. He doesn't die of his wound, but he dies of starvation 3 weeks later because he can't eat. So facial wounds are survivable, but sometimes not. Again, I mentioned if you're shot in the chest, it's not universally fatal. It just depends on whether the important stuff is injured or not. I think we mentioned you're shot in the abdomen, it's going to hit the bowel where bacteria live. You're going to get peritonitis, no way to fix that, no antibiotics, highly fatal rate. If the shot goes lower, down there and you get shot in the bladder, virtually the same thing. Peritonitis ensues. The tube carrying urine from the bladder to the exterior part of your body is called the urethra. If you're shot through that, A, it's where no man should be shot, but some people are, including Joshua Lawrence Chamberlain. His wound that he incurred at Petersburg was an injury through the urethra. What happens with that, as distasteful as this may be, is you develop fistulas. Fluid comes out in places that it's not supposed to. Now, it's my understanding, and there may be more knowledgeable people about Chamberlain than me, but I think I have heard his wife's and his relationship was tempestuous. I can see if a fistula was there, it would cause tempestuosity. Nerve injuries are rather select. They can be very disabling, and one of the last quotes we'll talk about is a gentleman who specialized in nerve injuries. And extremity injuries, most of the injuries, 2/3 of them were in the extremities. We're going to talk in some detail about, because those were survivable wounds in the Civil War.
So Rick, when we put this lecture together, I said, we need a hero. Got to have somebody that we'll talk about that's helped soldiers back then and helps you and I today. And do you have one for us?
Yes, we do. And this gentleman paid homage to the gentleman that Fran and I are going to talk about in the Second World War. Major General Paul Hawley was the chief surgeon of the European theater in World War II. And I won't read the whole quote, but just look at the last sentence. There was not a day during World War II I did not thank God for Jonathan Letterman. So who is Jonathan Letterman, and why is this guy thanking God for him? Jonathan Letterman was the medical director of the Northern Army of the Potomac. He got his job on around July 4th, 1862, a full year before the Battle of Gettysburg. He did many things, and we have a list here that we think are very important, but one of the first things he did was to standardize the ambulance trains in this army. Believe it or not, ladies and gentlemen, the ambulances were controlled by the Quartermaster Corps, and we're even through a good portion of the Civil War. And the quartermasters are interested in getting provisions and food and blankets and material to the front line. They're not interested in evacuating injured soldiers or getting medical supplies up. Letterman made sure that happened, and he did it in such a standardized fashion that every Union Corps had 3 hospital trains. Each train had lots of wagons, lots of men, and each ambulance had somebody who could litter people into the ambulance and drive the ambulance. So every ambulance train was basically the size of a regiment, 354 fighting regiment at Gettysburg. So these were big deal outfits, and many of you may recognize this picture of an ambulance corps training, but this is a picture of an ambulance corps being readied or getting supplies. Some of these wagons are 2-wheeled. What were they called, Fran?
Avalanches.
Avalanches, because when you were a soldier in there, it bounced around. None of them had springs. You didn't know where you were going to end up. Now, and if you go out to the Lutheran Theological Seminary in Gettysburg, there's an ambulance outside there in its legacy as a hospital. It's a 4-wheeled, more modern ambulance, and you could get more soldiers in there than the 2-wheeled one.
And you have to think about these soldiers. You talk about the 17-mile train of tears that Robert E. Lee took out of Gettysburg. My God, let me out. Put me beside the road. Let me die. Give me a gun. My God, get me out of here. If you've ever had a broken bone, you know what it's like when you just move it. Now put themselves on something with 2 wheels that bounces and goes, and we talk about the battle for another tomorrow. We talk about Jonathan Letterman. So what can Rick and I tell you looking back 150 some plus years? I can tell you one thing about the medical corps. They hate to lose. I can tell you today, in a modern OR, in a modern trauma, the medical team hates to lose. They're not going to let you go away. But look at those injuries and where they're going. Jonathan Letterman has a lot for you surviving today, if you've been in an accident. The ambulance corps, immediate care for soldiers, chain of command, adequate detail. Rick, tell them about an operator. Because it's not meatball surgery. Letterman won't let this be meatball surgery. Tell them why. There's
physicians, there's surgeons, and there's operators. Operators were the best surgeons to be had. They were appointed because they had good hands and they could operate very effectively better than anybody else. It had nothing to do with rank. It had nothing to do with experience. It all had to do with who could operate the best, and they were called operators. And it was their job, as we'll talk about, to sometimes do the superhuman effort of taking care of these wounded people.
And they would have a quick consultation. We call it a pre-op consultation. Rick and I have had the honor of doing some lectures at a Civil War hospital. People see a barn. We see a hospital. We see the ER. We see pre-op. We see the OR. We see post-op. We see the wards. We see the morgue. We see materials and supplies. We don't see finance and administration. So we see that.
That was paid for, I think.
Paid for, yeah. But he also introduced a triage system, and it was pretty easy. Mortal, surgical, or minor. All right? You saw Rick go over those wounds. Imagine the capability of a surgeon on the battlefield going to young men, 19 to 24 years old, and saying, "I'm sorry, son, your wound's mortal." And now you start getting the battle for another tomorrow. He lays the pathway to 1 golden hour. Since you went to shock trauma, tell them what 1 golden hour is. And that's why hospitals are so close, right?
Right. The golden hour concept, and we still live by it, is that your body has so much time and it's limited to protect itself before everything starts to fall apart. Rapid evacuation, even in civilian casualties that we all face, rapid evacuation by helicopter to major trauma centers where they have systems in place. At our hospital, and we call it trauma alert, 14 people respond. They're ready to do what needs to be done in a timely fashion. People only have so long to live when they're bleeding from their liver or if their femoral artery has been cut in a bad car accident. And the appreciation for this goes back to Jonathan Letterman.
So what about the Confederate Air Force? Why didn't they use that?
It didn't.
Not just.
Just a nod to Jonathan Letterman. Many of you who, again, know the layout of the Battle of Gettysburg, there's one lonely historical marker on Route 30 East, a couple of waysides in the parking lots like at the Giant store, a brand new wayside at the historically accurate Sheets there on Route 30. But nonetheless, it gives homage to Camp Letterman. Camp Letterman, we're going to talk about the different type of hospitals. Camp Letterman is a general hospital, a tent hospital that was established in the village, the borough of Gettysburg, to take care of patients who were too badly injured to move to York, Baltimore, Philadelphia, or other northern cities. So it is a general hospital. You can still find some of the roads and hills. It was put in a great location right up behind the state liquor store, really. It's up on a hill. There's a water tower up there that if people are interested, you can point out to where Camp Letterman was.
Well, let's get to the surgery end here. We've told you about the medical conditions. We've talked about a soldier being injured. Now we got to get them to the hospital. We know we have a transport, so let's talk about the hospitals. So we're going to use what we know best. Now some of our fellow guys might say not yet, and we will agree with that we're trying to know better. At Gettysburg, the first stop when you're injured is the person by you or you. You have a tourniquet, direct pressure, you know how to stop bleeding if you can do that, if you're conscious. Then they take you to a field aid station where they would do the same thing. They would stop hemorrhage. They would try to get you first aid, basically, we would call it today. But there would be a surgeon up there, probably not an operator, who'd be making those life and death decisions. Mortal, surgical, minor. And starting to triage them to get them off to the ambulances. The next stop would be the field hospitals. And these are the hospitals that are close to any Civil War battlefield. You'll see them there. And Rick's going to talk a little bit more about what happens there in a second. But your next stop would be a field hospital. And when you get there again, now you can see this funnel of patients coming. And now the operators are going to do their pre-op and say, all 5 of you need an amputation. 1, 2, 4, 5. They're going to start triaging you again. Because, like anything else, it's a rate-limited resource. And then after the field hospital, Rick, what's next?
Well, after the initial stabilization at the field hospital, and many of you may recognize that monument to the field hospital on the Battle of Gettysburg, to Z. Boylston Adams up in the wheat field on the Stony Hill. That was a triage station. There were others all over the battlefield. That's the only one that I know of that's marked. The field hospital is where the real work was done, and that's where most of the surgery was done, and then you were evacuated to a general hospital. If you could be transported via railroad, you were taken to the railroad and put in ambulance trains, on ambulance trains, in ambulance cars, and taken to a general hospital in Philadelphia. This is Camp Satterlee, which was a very large general hospital, I believe on the western side of Philadelphia. Camp Letterman was a general hospital. The initial surgeries were not done at Camp Letterman. Follow-up surgeries for things that we'll talk about, like infection, hemorrhage, occurred here, but it wasn't the bulk of the surgery that was done at a general hospital. The Confederates had the same system. This is Chimborazo Hospital in Richmond, which may have been the biggest hospital on either side in the American Civil War. So this was a very tiered way to perform this care. What kind of surgery could be done? Well, we've mentioned in passing that general anesthesia was available. I think it's important, and the general public continually is surprised by this fact. 95% of all surgery in the Civil War was done under general anesthesia. What kind of anesthetics did they have, Fran?
We'll get to that.
That's right, we will. It wasn't just amputations, but as we said, if you were hitting the abdomen, if you were hitting the brain, there really wasn't much that could be done. If you were lucky enough to have a depressed skull fracture from a piece of shrapnel denting your skull or falling, that could be raised up with something as medically sophisticated as a fork. In many of the surgeons' kits, they had two-tined forks that they would raise that up with. We've talked about facial wounds and how they could be survived. Chest wounds, many of you have heard the term a sucking chest wound. Your chest cavity has negative pressure. If you put a hole in your chest, your lung collapses because air rushes in. Then when you breathe, the air moves in and out. There were no chest tubes to put in people in the Civil War. Abdominal surgery, virtually unheard of. If your guts were hanging out, you were going to die. If you were even shot in the belly, you were going to die. There are cases of soldiers who survived what's called an evisceration, where their bowels were hanging out. Standard treatment was to wash it off with water, put it back in, and put a bandage on it. Some people actually survived that wound. But the bulk of surgeries done in the American Civil War were amputations. They were done early. It sounds like voting in Chicago. They were done early and they were done often. Why were they done early?
Some of those guys are still voting.
Yeah. Why were they done early? There was this concept of the irritative stage. We now know that as early infection. The surgeons in the Civil War didn't. But they knew they had to get to these soldiers and get the operation done fairly early. And even some of that translates to how we take care of, not necessarily accident victims, but there's an appreciation in my specialty for getting people taken care of, not irresponsibly quickly, but quickly, within the first 24 to 36 hours. Even things as common as hip fractures, we try to get to the operating room fairly quickly.
Okay, so the American Civil War ended 152 years ago. And with all the advances in medicine, the problem is we're still dying of the same things today that we did. Now we've gotten our nutrition better, and we've gotten things better, but you're going to hear Rick and I talk and take somebody through surgery here, and you're going to be pleasantly surprised to see all we've done is enhance. Every war, unfortunately, advances medicine faster than it should. But it does. We're going to talk about it. So, okay, Rick, we've got a soldier. He's at the field hospital. The operators have agreed that a BK amputation is going to be indicated for this gentleman. Let's do the case.
So, it did exist on the battlefield, Fran. Tell us a little bit about anesthesia.
So we have two anesthetics available in the Civil War, ether and chloroform. By far, chloroform was used more than any one. Ether had an annoying problem of blowing up. So if you're going to be working under a kerosene lantern, well, you get the picture, right? But they're very good, and what they are liquids that vaporize. And before you say, oh my God, you're going off into right field, if you've ever filled a car up with gasoline, what you smell is the vapor. They work the same way. Now, you think, oh, how old are they? I bought anesthetics, empty anesthetic bottles, and you can read the chemical structure. They're ethers. But now we've added stuff to them so they don't blow up. Ether was discovered as a guy trying to make pesticides. And the smell that came off did pretty good. And actually, General Jackson will say it's a miracle when he's having his arm amputated from the anesthetic, doing that. So we had those anesthetics.
But then, you know, probably almost everybody here has seen the movie Gettysburg. Remember that scene when Thomas comes back and says, Lawrence, it's awful over there in the hospital. They don't even have an anesthetic.
I know, and I have to explain that. So, what happens? Well, my friend Rick will tell you, now that I do administration, one of the biggest things surgeons complain about are lights. So they would rarely work inside. They would try to get out in light, so they'd be out where people could see them. And what they would see is how humans go to sleep under an anesthetic. Just like today. Just like today, you go to sleep the same way. You haven't changed much in 150 years. So what happens? You're wide awake. You just don't go from awake to surgical anesthesia, you drift. And if you can recall going to sleep under anesthesia, most people go down. I don't know why. It's always described as, I drifted down. They go down. But there's a stage between awake and surgical anesthesia. We call it hyperexcitability in anesthesia. But if there's a loud noise, somebody moves a broken bone, you will have a reaction to it. You'll scream, you'll roll off the table, you'll jump. Rick's watching to fix the leg. I'm putting them to sleep. Soldiers are marching by an open battlefield, and we think they're seeing the excitement phase of anesthesia. That's why he tells Lawrence there's no anesthesia. As you drift down further, you get to the surgical anesthesia plane, and then I go to Rick, go for it. But in the Civil War, as soon as I start noticing that you're too deep, I start waking you up. That's why he has to go faster. And then you have to remember that they come out going through that phase of excitement. So what type of monitors did they have in 1863? What they could see, what they could hear, and what they could feel. Now, 2017, my CRNAs and I still use those same types of monitors because they're still the best ones we have. We've added a couple of things, but we're still watching for the same thing. We're still watching for the same things. This one up here is all heart monitors. This one here is all just a ventilator on an anesthesia machine. So, how would I put them to sleep? Well, I have to do something to get that inhalation in you, and this is called a chloroform funnel. This is a reproduction. You would take chloroform or ether, you would measure out 2 grams, you'd shove it in here, and then this will go over the soldier's face as a mask. This is a modern anesthesia circuit. See the funnel? Hooks to an anesthesia machine. See this? This connects to the anesthesia machine. You're welcome to come pick it up. I can put you to sleep. We haven't done anything better than this, if you have it. But this is what an anesthesia machine looks like. You can see that vaporizer that I held here. You can see the person putting it over. But now I can paralyze you. I have drugs that will paralyze you, and I can run a ventilator on you. They didn't have it in the Civil War. So that's what the steward, wasn't even a CRNA, would be watching for when you get down. Okay, Rick, I got him asleep. We've noticed that the leg is, here you go. We've noticed that the leg is relaxed. You got 6 minutes.
And I'm going to start doing my job when the patient is anesthetized, not necessarily not moving. That phase of excitement, there's 25, 30, 50 more young men laying over there that I got to take care of. As soon as the patient is unaware and not feeling pain, I'm going to proceed with the operation. And an amputation in the American Civil War, folks, is not that much different than the amputations that we do in 2017. Oh yeah, that'll end the talk. While we don't bring our instruments into the operating room in velvet-lined boxes, they're laid out sterilely now. These amputation knives, ladies and gentlemen, are still on the back table in 2017. The saw has a battery on it now so that I don't have to do this. But those instruments are not that much different. In a controlled operating environment like Fran and I work in, if we do a below knee amputation, I know that that's the only one I'm doing that day probably. There aren't 25, 30, 50 more people there. I can take my time. It takes about a half an hour. In the Civil War, 5 to 8 minutes. And the operation that was done then is pretty much the operation we do now. You mark out where you're going to remove the limb with consideration of what level we need to do to make this soldier safe, what level of function they'll have. You take a knife and you cut down to the bone. You then take the saw, you cut through the bone, and the third step is you take one of those big amputation knives, you go through the cut in the bone and out the back of the leg, either creating a round stump or a flap, but there's not much more to it than that. And along the way, you get a hold of the largest vessels you can and tie them off. There are certain vessels that absolutely have to be tied off.
So my question is, when you're going to do an amputation today, and it's very rare, usually it's a vascular failure, you have to be thinking about the same things that they thought of in 1863. Give me the three biggest things you're thinking about while I'm putting them asleep.
Well, the first thing is, what level are we going to do this at? Especially if it's a trauma patient. They may have shattered their lower leg. Can we take it off below the knee and save function? Or are we going to have to go above the knee? We got to control the bleeding. Usually, you'd be surprised on those occasions where I've seen traumatic amputations in the field and the patient is brought in. They don't usually bleed to death. Their vessels spasm off and it's not shooting out. I had a patient once tell me that, "Doc, I hit the guardrail on my motorcycle, I went flying, I looked up, my leg was over there," and I said, "That's not good." They do survive these traumatic amputations, but we have to control the bleeding, obviously, in the operating room.
So that hasn't changed.
That hasn't changed. And then we want to sew it up in a way that will promote healing. Now, that might be a little different now than it was then. Wounds were closed, but they were loosely closed with sutures. Some of them were silk, some of them were horsehair that had been boiled to make them soft.
This is something else. This is our favorite picture. We've worked hard to get this so you can see it. This hasn't changed.
Yeah, this is still the OR team. Here's the surgeon, here's the patient. Here's Fran with his nifty anesthesia funnel, and this is the guy who's going to take the leg off and move it away, which is not the fun job to have. It's just very surreal.
But there's a little more pressure in this.
Yeah, this guy in the back seems to be smiling and have a bayonet
on his thing.
Yeah, we're not really sure why that
We're
is.
still a highly regulated business. We're pretty sure that's the Department of Health.
Right.
So Rick, how did they do?
How did they do? They did okay. The mortality rate of all the amputations, estimated 70,000 amputations in the American Civil War, about 1 out of 4 died. You would think it would be much worse than that. The majority of them got infected. We talked about no realization of antibiotics. Germs weren't even being realized as a theory of disease yet. Many of you have heard the term laudable pus. What's laudable about pus? That type of pus means the wound is going to heal. Other types of infection were a problem. Noxious effluvia, I'd like to put that in the medical chart now, but it involves things like blood poisoning, flesh-eating bacteria known as erysipelas, gangrene. We had antiseptics to take care of wound infections. We just didn't have antibiotics, Fran.
Yeah.
And the results beyond infection, Jonathan Letterman was very critical of the surgeons who didn't take off enough limbs. This is a race against time. You can save the extremity, it doesn't always work very well, and it takes longer, and that's really not very functional above and beyond a prosthesis. But death from surgeries was more common than nowadays, and actually the science of embalming evolved in leaps and bounds during the Civil War.
Yeah. My dad was an undertaker, funeral director in Altoona, Pennsylvania. When he saw I was going into medicine, he said, "Fran, we're in the same business, and you don't," when your dad says something like that, you look at him and says, "All I do is cover up your mistakes." I get it. So how about anesthesia? That medical OR that Rick told you at the beginning, there's under 100 reported deaths from anesthesia. One, from a surgeon saying making them deeper, so I don't count that one. That was to do that. But actually the anesthetic was very safe. The good thing about chloroform and ether in jars, you couldn't kill somebody with it. Because you would start breathing it, and you would never, before you died, you'd stop breathing. And as soon as you stop breathing, you come up. You got to remember, the lungs is just like giving medicine in the IV. It was a clever way to put somebody to sleep. If you lay your lungs out, they're the size of a tennis court. And it's one cell between the blood and the air. So it was very safe. It was hard to do it. What did they die of? Things that people die of today. Aspiration, right? Bleeding, shock. It's the stuff that makes it to our peer reviewer course all the time. Right, Rick?
Well, hopefully not all the time.
Yeah. All right. So we're coming down to the end here. We want to have some time for some questions. So, Rick, I'm going to put you on your time machine. Here you go. What 3 things do you want to bring forward that would have saved many men's lives?
This is an intriguing question when we asked ourselves this. What would we want now? Well, first and foremost, I want antibiotics. Penicillin really wasn't even discovered until many years after the American Civil War, but it's a game changer for obvious reasons. I want a clean operative environment. I now know that wearing all of these gloves, hats, gowns makes a big difference. In modern clean surgery, ladies and gentlemen, 1% or less is the infection rate that we expect. People can die of overwhelming infection, but it's not common. And lastly, I mentioned controlling bleeding. We have a machine called a Bovie, which we can burn small vessels with and stop bleeding much, much easier than anybody could in the American Civil War.
And modern ORs today use this device. It looks like a robot. It's called Schroeder. It's about as tall as me. When Rick's done, we clean the room, we put Trudy in there, and ultraviolet light goes through and starts to kill bacteria in places that we can't even see. We fight it all the time, but it's on everybody's body. Now it's my turn. What three things do I want? Well, first of all, IV fluids. This is one of the devices we use. It's called a Belmont infuser. I can put a 2-liter bottle of fluid, soda bottle, on somebody in less than 15 seconds using that. I can hang blood, and I can push stuff into people to save their lives. I could keep them alive long enough for Rick to do his surgery. I would also want hollow bore needles. They're available, but not really being used because they're too thick. You'll read somewhere they'll take morphine tablets and they'll crush it up and stick it underneath. But to gain access to somebody's vein or artery, are you nuts? That's crazy medicine in 1860. But hollow bore needles alone and IV fluids, I can tell you that mortality rate would be cut. Just guaranteed of doing that. And finally, I want bags and bags of cross-matched blood. Now, in those records, there are 2 transfusions. First, they took blood from a stout German. Don't ask me why. They injected it into a patient, about 10 ounces, and he got better. Well, if it works once, it'll work twice. They find another stout German. Why is it German?
They're all stout.
They take 6 to 8 ounces of blood, they inject it into a patient, and he immediately dies. Well, we know that's from a transfusion reaction. So how to get away with the first one? Sometimes you'd rather be lucky than good. So one of them was a universal donor. They're cross-matched. One was a universal recipient. We don't know that. But as we finish up here, Rick, let's talk a little bit about the heroes that we want to recognize here today.
There are many heroes on Civil War battlefields, and those of you who have been to battlefields, gone on tours, lots of different types of heroes. Fran and I are here today to tell you about some of the heroes maybe we don't think about. Physicians in the Civil War, 11,000 served, 336 died. 51 were killed in action, 4 died in prison camps. Like the general soldier population, the majority of them died of disease. If you have had a cut on your hand and you're taking care of somebody with hospital gangrene, you're going to get gangrene. There was a soldier at Gettysburg, a surgeon at Gettysburg, killed at a forward aid station up near the Catherine Gwynn House across from General Meade's headquarters. He was at that forward aid station. A piece of artillery ripped his thigh open, didn't damage the vessel, didn't damage the femur, but 3 days later, Dr. William S. Moore was dead of a gangrenous death from a soft tissue injury sustained in that battle. As we close out, I don't think Fran and I can do justice to this without telling you in the words of some of the people who were there what they experienced. So I want you to try to go back and put yourself in the middle of this scene. We'll choose Gettysburg, because many of us know it very well. What Jonathan Letterman described and what he saw was a field of blood on which the demon of destruction reveled. Surgeon Daniel G. Brinton, I think served with the 2nd Corps Hospital. The wounded soon began to pour in, giving us such sufficient occupation that from the 1st of July to the afternoon of the 5th, I was not absent from the hospital more than once, and then but for an hour or 2. 4 operating tables were going night and day. The tremendous physical challenge that these men faced, they felt just like any other soldier would feel. And remember, their work started at the beginning of the fight And it didn't end on the afternoon of July 3rd after Pickett's charge was over. These men, these hospital stewards, continued to work continuously. Let me just read a couple of passages from one of those. Dr. Bushrod James, no written nor expressed language could cover and picture the field of Gettysburg. Blood everywhere, tattered flesh, shattered bones. It was a mess. And the horrible silence of torture beyond all expression. Those weeks of sickening work when the cut of the knife and the rasp of the saw grated on my overtaxed nerves. And as we end, and we have more that we can talk about, and we'll certainly be up here for questions. We have some devices we can talk about. But let me close with a quote from a doctor who basically became the founder of neurology, S. Weir Mitchell. Dr. Mitchell was writing in 1914, and bear with me, this is about 2 paragraphs. We had served faithfully as great a cause as earth has known. We had built novel hospitals, organized such an ambulance service as had never been seen, contributed numberless essays on disease and wounds, and passed again into private life. What has been our reward? The great leaders in war have been promoted and universally honored. Countless statues commemorate in Washington and elsewhere the popular heroes. Statues of generals are in every town, some of them memorials of men that were wiser to forget, some of whom history will judge severely. Every village has its statue to the private soldier. There is not a state or national monument to a surgeon. At Gettysburg, every battery site is marked with a recording tablet. Every general who fell, Union or Confederate, is remembered in bronze or marble. But what of the surgeon who died? Nothing. Ladies and gentlemen, we think these are some of the true heroes of the Civil War, and we're honored to stand here and talk to you about it. And thank you very much for your attention. We'll take questions.